Hello everyone and welcome to this new lecture in our ECG course. We are discussing today a new topic regarding intraventricular conduction disturbance, and we are focusing on the first part of this topic, which is the bundle branch block. Let's start our talk today by a brief discussion regarding the conductive system of the heart. First of all, we know that the first part of the conductive system starts in the normal pacemaker of the heart, which is the SA node, which lies in the right atrium in the subepicardial region. From these SA nodes arise internodal tracts, which are three internodal tracts: anterior, middle, and posterior internodal tracts, transmitting the impulse to the AV node, and also the Bachmann bundle, which transmits the impulse from the right atrium to the left atrium, resulting in left atrial depolarization. Then we have like a transition as the AV node, which lies in the right atrium in the subendocardial region, and this explains why it is liable to damage sometimes during ablation procedure, because it lies subendocardial, whereas the SA node is deep structure lying subepicardial. And from this AV node arises the His bundle, or sometimes it is called AV nodal tract, which lies deep inside the interventricular septum, and then it bifurcates into right bundle branch and left bundle branch. And of course, we discussed before that the left bundle branch, of course, bifurcates into another two branches, which are the left anterior fascicle and the left posterior fascicle. And finally, all these branches regarding right bundle, left anterior fascicle, and left posterior fascicle, all of them bifurcates into multiple smaller branches, which are the Purkinje fibers, and these Purkinje fibers are responsible for transmitting this impulse to the ventricular myocytes, resulting in ventricular depolarization. So this is in brief the conductive system of the heart. So sinoatrial node arises from its AV node bundle of His, resulting in atrial depolarization, and then the bundle branch and the fascicles from the left bundle, from which arise the Purkinje fibers, resulting in ventricular depolarization, and this of course is reflected on the ECG as a P wave and complex respectively. So we are discussing today intraventricular conduction disturbance, which include a variety of disorders like left bundle branch block, right bundle branch block, intraventricular conduction delay, left anterior fascicular block or left anterior hemiblock, left posterior fascicular block, bifascicular and trifascicular block. Today we are focusing on the first three items of these disturbance, which is the left bundle, right bundle, and intraventricular conduction delay. Let's start, of course, at first by discussing the normal ventricular depolarization. We know that in the normal ventricular depolarization, we discussed this image before in the ventricular enlargement lecture. So we know, of course, that we have the left bundle branch in the left ventricle and the right bundle branch in the right ventricle. Each of them is responsible for depolarizing the ipsilateral ventricle, and we have the chest leads here from V1 to V6. We know, of course, that the septal depolarization is in left to right direction, and this results in a small R wave in V1 and small Q wave in V6. And then we have the left ventricular depolarization and right ventricular depolarization, and as we discussed before, left ventricular depolarization predominates right ventricular depolarization because of larger muscle thickness in the left ventricle, resulting in deep S wave in V1 and large R wave in V6. And of course, the chest leads from V2 to V5 are like in transitional stages between V1 and V6. So this is regarding the normal ventricular depolarization. Now we are discussing bundle branch block. We know, of course, that depolarization of the bundle branches and the Purkinje fiber are seen as a QRS complex on the surface ECG. And so with bundle branch block, you will see two changes on the surface ECG: change in complex morphology and increase in complex duration. But what is much more characteristic in bundle branch block and much more important for diagnosis is the change in complex morphology. And of course, when we say this, we need to know why. Of course, we know that this is the normal ventricular depolarization that we discussed before. But in case of left bundle and right bundle branch block, it is not normal. The direction of septal depolarization may be reverted, like in left bundle branch block. And of course, the direction of left ventricular and right ventricular depolarization may also change due to block of one of these bundle branch. So disruption of the normal direction, of course, will lead to change in complex morphology, and that's why left bundle branch block and right bundle branch block have peculiar morphology in complex in the surface ECG. So this is regarding complex morphology. But why does the complex widen in bundle branch block? Because of course, when the conduction is blocked in one of the bundle branch, it takes longer time for the electrical signal to pass through the ventricle, because the impulse has to travel, for example, from the intact ventricle in which the bundle branch is intact to the affected ventricle in which the bundle branch is blocked. This of course will lead to increase in the complex duration. So in most cases of bundle branch block, you will find widening of the complex. But because it is like a degree or a variation from mild affection to severe affection, we have two terminologies. Complete bundle branch block, in which the complex duration is more than or equal 120 milliseconds, and incomplete bundle branch block, in which the complex duration is increased but it is still less than 120 milliseconds. So don't wonder if you found complex or left bundle branch block morphology or right bundle branch block morphology with complex duration less than 120 milliseconds. And that's why complex morphology is much more important for diagnosis of bundle branch block rather than complex duration. And so remember this idea in your mind, in order that we know today that bundle branch block is a matter of complex morphology rather than complex duration. So let's start with the first type of bundle branch block, which is right bundle branch. Here we have an affection in the right bundle branch in the right ventricle. So septal depolarization will be intact in a left-right direction, and so you will have still the normal initial R wave in V1 and initial Q wave in V6. Then we have the normal left ventricular depolarization, no problem with this, giving rise to the deep S wave in V1 and the large R wave in V6. Then, in order that the right ventricle get depolarized, the impulse need to be transmitted from the left ventricle to the right ventricle through the ventricular myocytes, which take longer time because, of course, the right bundle is damaged here. And so we will have another large wave, which would be large R wave and wide in V1, and of course because it is a second positive wave we would call it R dash wave, and in the V6 we will have deep and wide S wave in V6. So we have RSR dash morphology in V1 and we have QRS morphology in V6, and we could understand why the R dash wave in V1 and the S wave in V6 are wide, because of course it didn't get through the normal conduction pathway through the right bundle branch. No, it gets transmission through the ventricular myocytes, which are or show slower conduction velocity in comparison to the Hess-Purkinje system. So that's why right bundle branch block gets like a normal or characteristic morphology characterized by the RSR dash right bundle branch block morphology in V1. So this is the characteristic morphology that we see usually in right bundle branch. We could see small R wave in V1 followed by deep S wave, and then we have a large and wide R dash wave in V1, and we could find also that in V6 it has the same characteristic morphology in the form of QRS. So of course remember that the second positive wave in V1, which we call R dash, is longer and wider than the initial R wave in V1. So usually the second R is larger and wider than the first R wave. Now we need to know what are the diagnostic criteria for right bundle branch block. Of course, in most of the cases, you will find broad complex more than or equal 120 milliseconds in case of complete right bundle branch block. But of course, in case of incomplete right bundle branch, it would be less than 120. We would find also that RSR dash pattern in V1 to E3. Sometimes we call it M-shaped QRS morphology. We sometimes find wide and or slurred S wave in the lateral leads like 1, EVL, V5 and V6, and this is like equivalent to the R dash wave in V1, which is a wide and deep S wave. And of course don't forget that incomplete right bundle would show the same morphological criteria, but the complex duration would be less than 120 milliseconds. What are the expected causes of right bundle branch block? Sometimes it's normal variants, so don't forget that some patients or some individuals, because they are not patients, may have normally right bundle branch block and they are completely asymptomatic, and if you follow up them for a long time, they will not develop any symptoms. So please reassure them that they have like a normal variant abnormality in their ECG. Check their echocardiography, check their symptoms. If they are completely asymptomatic, just reassure them. But some pathologies may cause right bundle branch block, like right ventricular hypertrophy, pulmonary hypertension, pulmonary embolism, ischemic heart disease, myocarditis or cardiomyopathy, degenerative disease of the conductive system like Lev disease or Liniger disease, and of course congenital heart disease affecting Mealy's right ventricle like ASD or tetralogy fallow can show right bundle branch block. So of course this is a characteristic morphology here of right bundle branch block, in which we could find the RSR- in V1 and V2, which are right precordial leads, and also in the lateral leads we could find the QRS pattern, and sometimes you could find the slurred S pattern that is characteristic in the lateral leads, and as we mentioned before, the slurred S wave is equivalent to the R dash. Here we could find also the same. And here it's very characteristic that we could find the slurred S wave in the lateral leads. We could see it in lead 1, we could see it in AVL, V5, V6, plus lead 2 as well. And as an equivalent to it, we could find a large and wide R wave in AVR. So what is a slurred S wave? The slurred S wave, as we mentioned, is the same equivalent to the R dash wave in V1. So don't be confused when you find the slurred S in the chest leads or in the lateral leads per se, because in the lateral leads you can find the slurred S representing the delayed right ventricular depolarization caused by right bundle branch block. So here we could find another example of right bundle branch block. We could find that there is complex morphology characteristic of right bundle branch block, like the RSR- pattern in V1, and we could find the slurred S pattern in lead 1. We could find it as well in lead V6, and the same morphology in AVR. But the complex duration here is slightly or relatively narrow, as it is less than 120 milliseconds. We can't call it completely normal complex duration. It's slightly prolonged, but not above 120 milliseconds, and that's why we call it incomplete right bundle branch block. And so we remind ourselves again, bundle branch block is a matter of complex morphology rather than complex duration. So remember, incomplete right bundle can be seen in about less than 10% of general population, but sometimes in athletes you could find them in up to 40% because of endurance sports, and this doesn't represent any abnormality, just reassure them if they are completely symptomatic and their echocardiography is normal. So we have finished our talk about right bundle branch block. Let's move to the left bundle branch block. Here the problem is in the left bundle branch in the left ventricle. So septal depolarization, which normally flow from left to right direction, of course it can be left to right because the left bundle is affected, so it would be right to left as a reversal to the normal direction. So here in V1 and V6 I could expect that I would not find the normal small R wave in V1 and normal small Q wave in V6. No, I would find like a start of negative deflection in V1 and start of a positive deflection in V6. Then the right ventricular depolarization goes in its normal direction, no problem with this, but the left ventricle would be slowly depolarized through conduction from the right ventricle to the left ventricle, through the ventricular myocytes, not through the Hesburger-Purkinje system. So the negative deflection complete in V1 and the positive deflection complete in V6, giving rise to QS pattern in V1 and broad R wave in V6. So I would not find initial Q wave in the lateral leads like V6 here due to absence of left to right septal depolarization, because the initial Q in V6 was caused by the left to right septal depolarization. Here it is not the case. It would be reversed in direction. I could find QS pattern in V1 and broad R wave in V6. So this is the classic morphology for left bundle branch block. Like here, V1 can show QS pattern, it may show small initial R, and V6 shows this large broad S wave, which may be sometimes pivoted like here or notched in this case. What are the diagnostic criteria of left bundle branch block? QRS duration, of course, is more than 120 milliseconds in case of complete left bundle branch block. Dominant S wave in V1, or sometimes we call it QS if there is no small R wave, or if there is a small initial R, I could find deep S wave in V1. Broad monophasic R wave in lateral leads like 1 EVL, V5, V6. Absence of initial Q in lateral leads is a very, very important diagnostic criterion. Prolonged R wave peak time, which is from the start of the complex to its peak, is more than 60 milliseconds, especially in left precordial leads like V5 and V6, because they overlie the left ventricle directly. And don't forget, incomplete left bundle branch block can show the same morphological criteria but with complex duration less than 120 milliseconds. Associated features, of course, are very common, like sometimes we can find something called appropriate discordance, as the ST segment and T wave move in the opposite direction to the mean vector of the QRS complex, and that's why it is accepted to see ST elevation in V1 and V2, which are predominantly negative, up to 25% of the depth of S wave, and secondary 1 mm ST depression and T wave depression or T-wave inversion in V5 and V6, because we know in V5, V6 the complex are predominantly positive, so there could be ST depression. This is what we call discordance, and of course we are discussing this topic in more detail in the lecture of ischemic change in the ECG in the topic of Scarboza criteria. And don't forget that, of course, in most of the cases, left bundle branch blocks show poor R wave progression in the chest lead plus left axis deviation. So left bundle branch block can show appropriate discordance, poor R wave progression, and left axis deviation. We need to ask a question. What is the expected complex morphology in V1? It's an easy question. Either we could see small r followed by deep S wave, which we call RS complex, or QS complex in V1, in which there is large negative deflection without any positive waves. But in V6 you could find some variation in the complex morphology apart from the classical pattern. We could find M-shaped complex like here, we could find notched complex like here, we could find the classic broad monophasic R wave, and we could find sometimes R wave followed by small S wave. But in V5, V6 usually the complex is predominantly positive in case of left bundle branch block. Now we have a question that of course many of us have seen in our practice, and so we need to answer this question. Why do sometimes we find QS pattern or RS pattern in V6? What I mean is that sometimes patients with left bundle branch block may have deep predominantly negative complex in V5 and V6 despite it is left bundle, and the expected morphology should be predominantly positive complex like broad monophasic R or even notched or M-shaped. And the answer is that in some patients who have LV systolic dysfunction, they have dilated LV internal dimension, resulting that the complex morphology in V5, V6 may seem like the same morphology in V1, V2. We need to understand why. We know, of course, this complex or the pattern of ventricular depolarization in case of left bundle branch block. We know that this is the classic morphology that we usually see in patients with left bundle branch block. But what about here? The LV is dilated, and so the apex is shifted much more lateral, and so most of the chest leads are facing the right ventricle and small part of the left ventricle mainly. So here left ventricular depolarization directed is away from the positive pole of V6, and so V6 can show deep QS pattern, can show small r followed by deep S wave, or can show large r followed by S wave, because V6 is not anymore opposite to the lateral wall of left ventricle as in normal condition. And so some patients with LV dysfunction and dilated dimension, you could find that the chest lead shows the same morphology from V1 to V6. And remember, the first sign of left bundle, as we mentioned, disappearance of initial Q in 1 and AVL because of the reversed septal depolarization. So it is like something impossible to diagnose left bundle in presence of initial Q wave in 1 and AVL because they are the high lateral leads. What are the expected causes of left bundle branch block? Sometimes we could find aortic stenosis as a cause, of course, ischemic heart disease, hypertension, dilated cardiomyopathy, anterior MI, degenerative disease of conductive system like left disease or Lehninger disease, which we mentioned in the right bundle, hyperkalemia, digoxin toxicity, and sometimes it is idiopathic, as some patients may have left bundle without any causes and they are completely asymptomatic. But remember, any patient with left bundle branch block, you should try to find a structural heart disease, and so this patient should have an echocardiography without just reassurance. No, we need to exclude presence of structural heart disease because it is a very common association with left bundle branch block. So we cannot consider left bundle branch block as a normal variant as in right bundle. No, right bundle is a normal variant. Sometimes they are found in normal individuals and in highly trained athletes. Left bundle is usually considered something pathological. Here we could find here like a classic pattern of left bundle branch block in presence of atrial fibrillation. We can find here that V1 and V2 show very small R wave followed by deep S wave, and it is wide, of course, because it is complete left bundle. And in V5, V6 we can find broad monophasic R wave in V6, and it is slightly notched in V5. Here we could find here like we have the same classic morphology in V1 and V2 and the same monophasic R, or it is slightly notched R wave in V5, V6, and also in 1N AVL we confine the notched R wave, and here of course we could see that there is no initial cue in 1 AVL, V5 and V6. So this is another morphology for left bundle branch block, and of course it is complete left bundle as the complex is much more than 120 milliseconds. Now we are going to discuss the third topic today in the intraventricular conduction disturbance, which is the intraventricular conduction delay. Here there is no problem in any one of the bundle branches themselves. No, just slowing down of the septal depolarization and slowing down of the left and right ventricular depolarization. So there is no block in one of the bundle branch, just a slowing down of the whole conductive system. So how can we differentiate between left bundle branch block and intraventricular conduction delay? The answer is in the initial cue in 1N AVL. In left bundle, the left to right septal depolarization is absent, and so there is absence of initial cue in 1N AVL, just a broad R wave, and there is preserved initial cue in 1N AVL because the septal depolarization is still present, but it is slowed down. So in intraventricular conduction delay, we could find that there is just widening of the complex duration without change in its morphology, because it's just slowing down, not block in one of the bundle branch. So here from the first impression, someone would say that there is left bundle branch block because of the complex morphology in V1, V2, and also V5, V6. But in 1N AVL, we could find that there is a still preserved initial cue in 1N AVL despite the wide complex, and so it is still intraventricular conduction delay, not left bundle. And someone may ask himself why that we have this dilemma in differentiating intraventricular conduction delay from left bundle. Does it really matter? Of course it matters, and that's why we are discussing this today. Because if the patient have LV systolic dysfunction, and we discuss his suitability for CRT implantation, which is a device causing biventricular pacing to improve the synchrony between the two ventricles, CRT benefit is much more in patient with left bundle branch block rather than patient with intraventricular conduction delay, and the cutoff point is different between left bundle and intraventricular conduction delay for implanting CRT according to the guidelines. So it is very, very important to differentiate LV left bundle branch block from intraventricular conduction delay. And so the term wide complex in ECG is a broad non-specific term that may include left bundle branch block, right bundle branch block, or intraventricular conduction delay. And so don't just mention wide complex in the ECG. No, try to focus on the complex morphology in order to say, yes, it is wide complex, but the complex morphology is changed, so it suggests left bundle or right bundle according to the features of this complex morphology, or it is just wide and complex but with still the same normal complex morphology, so it is just intraventricular conduction delay. And of course, remember that the most serious causes of QRS widening that very important to diagnose in clinical practice, and we need to exclude them if we saw wide complex in ECG, is the hyperkalemia and tricyclic antidepressant poisoning, which we are going to discuss in separate lecture. So at the end of our lecture today, we understand now the normal ventricular depolarization as we discussed its fundamentals today. We discussed it in the ventricular enlargement, and today we are discussing in much more detail in this lecture how to diagnose right bundle branch block, how to diagnose left bundle branch block, and how to differentiate between left bundle branch block and the intraventricular conduction delay. And remember our take-home message today: bundle branch block is a matter of complex morphology rather than complex duration, and also the first sign of left bundle is the disappearance of initial cue in lateral leads. Thank you very much for your listening.